Hello.
Good morning.
Good morning. How are you?
All right, yourself?
Sleepy. Wait a minute, let me turn you up. You low on my end, but it's me. Okay. How was your week?
Oh, good.
Good, good.
How about yours?
Productive.
Good.
That's why I'm sleepy. That's why
That's
I'm
good. Productive
sleepy.
is always good.
Right. Okay, wait a minute. You still low. Let me find out what's happening here. Um, la la la. Where are you? This here. This for me. Okay. All right. All right. Let me get rid of this. Welcome everybody to our wait, I hear some feedback. I hear some background noise. I hear something. But welcome everybody to our Saturday morning tea with my wonderful guest host. I'm gonna make him a full-time host. He don't know it yet. Mr. Jesse from the Coding Nurse. Um, make sure that you reach out to him and uh, join him. I don't. Can you hear me on Clubhouse? I'm
I
not.
can't.
I'm not blinking. Whatever. Make sure you. I can't do it now. Make sure you reach out to him and connect with him. He has a face or YouTube page. So reach. Do you have a Facebook page too?
No, I need to set it. I need to set it up because I can't promote on Instagram because I don't have my Facebook page set up.
Oh, sir, sir. I need you to get all of the things together. um. Oh, okay. Yeah. I have Instagram. I guess I need to be better about Instagram. It's so I've always done YouTube and Facebook, and so Instagram is like it feels like a chore because it feels like it's just something extra added. I mean, but I
Right.
understand that you can easily kind of just push stuff over there, and then with TikTok, oh my god, I don't even know.
It's almost like you need a social media manager.
Yeah, or something. It's
Just to be a
like
small, just to be a small little group.
all the things because really I guess in my dream world I'm a talk show host. I like to create stuff. I like creating content. I like all of that on top of what I'm supposed to do in my regular everyday profession and all the other things. But this is an outlet for me, I think. So I enjoy this as well.
Well, this I enjoy it too because it's good information.
Yes, yes. I really think, you know, back really when I was starting out and in the trenches, you always wonder, well, at least I did. How they know that? Where they get that information from? How did I get that information? And lo and behold, it's a matter of digging and looking for it, but it's out there. It's out there for you to find. It's out there for you to have. And so I feel compelled to help my fellow new person get the information.
Right.
So that's why I'm here. That's why we're here to share the information, share the love. Me and this son is about to fight. I done moved these blinds a gazillion times. And every time it's like it's slowly moving. Then the blind, it's like whatever it is. I'm sorry about the visual. It is what it is. Whatever.
That's right.
Because I'm not gonna move this space. Like my studio is in my office, but I'm not. This space is set up because I teach um, line dancing. That's a whole other conversation. But this is where I do that, and so this is already set up with the mixer to do all this other stuff that we're doing with the clubhouse and connecting. So I'm not gonna move it. So I don't know what to do, but we'll figure it out. Anyway, well, welcome everybody to our wonderful, wonderful show today. And as I mentioned to you, I had a couple topics. I had a couple things to talk about. The first one is I'm not sure if you're familiar with the No Surprises Act. I did a video a while back. There's a part one and a part two. And basically what it is, when you have a provider that is not in network, but you receive services from that provider. So there's some instances where, especially in an or emergency situation, and you're going to the emergency department, the hospital could be in network, but that provider could be out of network. And in those instances, if that provider is out of network, that provider is, of course, going to bill for the services that they provided to you. You, wonderful patient, may receive a bill. And so the No Surprises Act is a way to combat that, to stop that, so that you don't get a bill. You don't. They can't balance bill you if that provider is out of network. The same thing occurs with. I do hear feedback, and I don't know why.
I don't hear anything.
You don't hear it?
It's clear. It's great on mine.
I don't know why. Where is it coming from? I don't know. Okay. The same thing occurs with ambulance services. So if you have to be transported, to a hospital or what have you, then you have that same situation with an ambulance service as well. So thus the Surprise Billing Act. But Medicare and Medicaid services, or CMS, they're actually hosting a special open door forum. And they do these occasionally for different things that they want to discuss and talk about. So they have a conference call scheduled this Wednesday, December the 8th, from 2 to 3 p.m. Eastern Standard Time. And it's really to just talk about what the providers need to expect, because there's a second part to it. So the second part, the first part kind of itemized what is going to happen, what the providers will be responsible for, how they need to handle that. The second part is that they need to establish dispute resolution processes. And so they want to, in the event, well, I'm sure, not in the event, I'm sure it's going to happen. When it happens, they have a process put in place to determine any amounts between the out-of-network payment folks and the providers and facilities and health plans and all of that. So they need to put together, even though the patient is carved out of it, they still have to kind of battle and figure out what to do as far as that money. And then they need to require good faith estimates of all the medical items and services for any uninsured or self-paid patients. And then also have a patient provider resolution process. So, and then if folks feel that they need to appeal, then they need to also come up with an appeal process. So this whole webinar, and they also have, some slides or whatever that you can follow along, but the whole webinar, or I'm sorry, conference call, they're not gonna do a webinar this time, just kind of goes into more detail about that. So I thought that was interesting that they were providing that, because this goes into effect January 1. So folks need to know what to do in that provider world. Yeah, so I thought it was a good thing. I mean, a good thing, but then I think about the transparency, and I don't know the act off the top of my head, so forgive me, but the legislation that tells providers they need to be transparent in their pricing, and they're supposed to put in layman's terms what the prices are for the services that they provide. And folks are dragging their heels and they getting fines. And so I saw, I want to say it's in one of the final rules where they have increased the fines. They're like, oh, y'all think we playing? Because the providers don't want to do it. And so it was like, oh, y'all think we playing? So let's, how about we increase the fines? And so for the number of bed hospitals, they've increased what the fines are per day if they don't put this information out. And I'm like, wow. So I'm interested to see how this one is going to roll out with these particular providers, especially since they're like, we don't want to do it. we feel like we're being regulated enough, et cetera, et cetera, et cetera. So it's going to be interesting.
But I think this is important because, first of all, most people, there are people who are private pay.
Mm-hmm.
And what a lot of people don't understand, especially when it comes to healthcare, is that every bill can be negotiated.
Mm-hmm.
And most people don't know. Most people just think, well, this is what they say I have to pay. So what's this amount? No, it's not. But they don't know because nobody has ever told them.
Mm-hmm.
There hasn't been a real discussion. Because when you have insurance, that's what happens. The hospital never gets the full amount. If you just look at your statement, you can see they get way less.
Right. Right. And you, to your point, folks don't know. We don't know. We don't know what's going on. We just see like, okay, well, some people have the mindset of it is what it is. You'll get what you get.
Right.
Treat me.
Right.
So you got that part too. Oh, cool. Yeah. So it's interesting to see how all that's gonna fly. The other thing I wanted to talk about was there's some recent updates to the OIG work plan, and some things are broad and kind of go all over the place. I just wanted to mention three real quick. The first one is for telehealth services in select federal healthcare programs. So I don't know if you're aware that there has been a big push from multiple players to discuss or to allow the telehealth services to continue the way with relaxed restrictions that we've had due to the pandemic. And most of those restrictions kind of deal with the originating site, also allowing folks to use a tablet or a cell phone to have a telehealth service. And then there's one that's even more, I guess it's widespread, particularly and interesting for providers, is the restriction of the licensing across states for providers. And so those things have been relaxed. And when the pandemic ends, hopefully sometime in our lifetime, these restrictions will end. So there are a lot of groups that are being proactive and fighting to have Congress or those in power take a look at and see the benefits of telehealth, see, where telehealth has been provided, to see all of those wonderful things, and say, hey, this is a place where maybe, we need to keep these restrictions. So it's kind of dual-fold because like Congress has a piece to it, but then like the licensing restriction piece, I think lies at the state level. So that's a governor's action. But overall, part of, I know in the final rule, they have allowed for telehealth services to continue, like audio services in the behavioral health space. And so they kind of ticked theirs off and they got theirs stable, but it's not for all other services. And so the fight still continues for the other services. Nevertheless, the one of the pieces to allowing that was to kind of get some data. And so they need to figure out, what do these telehealth services look like? Who's receiving these services? Who's providing these services, et cetera. So the OIG work plan initiative pretty much is helping to understand, what the access is for the various levels of care that's being provided, and just really to collect the data to provide folks information about, what telehealth looks like, particularly across the federal healthcare programs, Medicare, Medicaid, TRICARE, all those things. So that was the one that they're looking at. That was kind of the broader one. The other one the other two is more coding specific. So, and these are audits. So and we talked about audit last week, so we know what joy we are in for when this audit comes out. But one of them is for payments for inpatient claims with mechanical ventilation. And really, it just talks about for certain MSDRGs to qualify for Medicare coverage, the beneficiary must have received more than 96 hours of mechanical ventilation. And they are going to go through and do kind of a medical record documentation and claims review to determine if they have truly received those 96 hours of mechanical ventilation. And unfortunately, there have been some previous reviews. So now the reviews and kind of up its game to an audit where hospitals had inappropriately billed for beneficiaries who did not receive at least the 96 hours of mechanical ventilation. So, yeah.
That's interesting because in ICD-10 PCS, that particular code is called a non-OR-DRG because there are some codes in PCS that can affect the DRG or increase the DRG, and mechanical ventilation is one of them. And that's going to be interesting because you have a lot of people who have mechanical ventilation for a lot of different reasons. You have people who are in, they might have severe sepsis and have acute respiratory failure, but does that mean that they had mechanical ventilation for 96 hours and not only had it for 24 or 48? So that's really interesting.
Yeah. So that one is going to be, like you said, interesting to watch, interesting to see. Hopefully they won't have some of those same issues as the audit we reviewed last week.
That's kind of cut and dry because you'll definitely see documentation when they started and when they stopped.
Right. There shouldn't be any questions of, this is that's the other, what have you. So
now what'll be interesting is if they find out, or some of these facilities have to pay back money because the respiratory therapy documentation was a little lacking. That would be something.
Yep. And then the other one, and they've been, I'm sorry, go ahead.
I said, good morning, Terry.
Oh, hi, Terry. I'm sorry. See, I can't put the thing up on the screen anymore, so I got to keep paying attention. Hi, Terry. Welcome. Feel free to come up to the stage in Clubhouse. Let me add you if you want to come. Oops. Let's see. Invite to speak. Okay. And the other thing is, and they've been talking about this for a while, malnutrition. And so they're looking at hospital claims with severe malnutrition. Now, since hospitals are allowed to bill for treatment of malnutrition on the basis of the severity. So it can be mild, moderate, or severe, and then whether or not it affects patient care. But severe malnutrition is an MCC, or major complication or comorbidity. So adding an MCC to a claim, of course, can result in increased payment, and that makes the claim coded higher or to a higher DRG. So they're going to look to see whether or not hospitals comply with Medicaid billing requirements when assigning severe malnutrition diagnosis codes to inpatient codes. So that's going to be interesting because that's more on the state, on the Medicaid side. So,
right. But are there any real clinical indicators for severe malnutrition? Because it's very clear, like that's what I've always found interesting. It's very clear what obesity is, what morbid obesity is in terms of BMI, and in terms of, there's many more guidelines that can help you with a diagnosis of overweight, obesity, or morbid obesity, but there's not anything really for malnutrition. It's really more or less based on the provider. but there's no like if your BMI is 16, what is that?
Right, you have something clear cut that you can easily say, okay, this is that versus, I don't know. I'll look into that. I'll look into that and see if there's something because there's something with that because they've been talking about malnutrition for a while. Go ahead.
And I think the reason why is because I know I've had experience working with providers and especially around malnutrition, and it's hard because there's no concrete language. And I just know that, like, I remember, I made a big deal out of it because I'm like, how can the person's BMI was 16 and the provider documented patient looks thin. Not with a BMI 16, you don't look thin. You're emaciated.
We can see through you, sir or ma'am.
Exactly. So then he put in like for a dietary consult. This was a PACE program, but nothing was that. Like you didn't order any Ensure. Like not like you got to do something. No. So I kicked it up to the medical director and showed it to her. So then she gets the regional medical director involved, and this book. You know how it is when you talk to providers, and he's trying to do this. My providers, they take very good care of their people. And look, you know me, I'm like, listen.
Here come the tea. Here come the tea.
Look, with a BMI 16, you can't sell me on good care, son. You cannot.
Somebody dropped the ball somewhere.
Exactly. All I'm saying is that we just need to fix it and like now. Not, we'll get to it. No. And I told him, I said, this is on, malnutrition has been on the OIG work plan forever.
That's what I said. It's not, and it's like something is up that it's still there. It's not moving. It seems like some low-lying fruit for real, quietly.
But it's because they need to come out with, CMS needs to come out with guidance on what is malnutrition.
And I think they want to know, or they have an indicator of what they I'm gonna look. You got me interested now. See, my brain is gonna be searching.
Because on the other end, look, they got the fat folks covered all day long,
sir.
It's very clear.
So it's like, well, why is it not clear? And maybe that's something that they would need to kind of do. Put some thought into to understand is the information or education that we're providing not enough, or people not getting, or is it not clicking? What is it? What's the disconnect? What is it that people are not understanding as it relates to that? And then again, kind of do some self auditing and to determine whether or not they have really made the message clear that this is what they're looking for. This is what needs to be documented. This is what the patient needs to present as, not this is what needs to be documented. That's a whole other conversation, but this is what the patient needs to present as.
Because I think, honestly, I feel like malnutrition, especially among the senior demographic, is way bigger than what people realize, because we have a lot of seniors who are food insecure.
Mm-hmm. Yes.
You have a lot of seniors who don't even get all their medicine because they can't afford it.
True.
So they are strapped financially, and not all of them have access or go to food banks for additional support. And
transportation issues. So there's a whole host of social determinants of health that are involved, which that's a whole other topic that we really need to tackle. But go ahead.
And I just think that there needs to be more of they just need to come out with some better guidance, and need to come out with some better additional support services, especially for that population. Because we see it all the time.
All the time.
I mean, we heard for years about the old lady who eats cat food.
Wasn't it on a Good Times episode back in the no?
Yeah.
I'll never forget that. I'll never forget that. Like, what? I was a child. It was like, huh? See, I'm telling my age. I was a child. It was like, huh?
There was an episode where they prayed like the Lord is my German shepherd.
Oh my God. See, something's wrong with them. Who was the writers of that show?
But that's how long it's been around.
Yes. Interesting. And then the last thing I had before we go into our normal powwow was there's a new edit 20, the unspecified code edit. I know a couple of folks will be talking about this particular edit in some exchanges and documentation coming up soon, but late October, Medicare released a change request number 12471, and I'll post links to all of this in the description box after the stream. But the edit 20 is for the long list, but there are certain things, but it's a long list of unspecified codes that are in ICD-10. And these are for circumstances when documentation in the medical record doesn't give the level of detail needed to support reporting a more specific code. So this piqued, I think, the curiosity of a lot of CDI folks. And particularly in the inpatient setting, it states that there are rare circumstances when you can't document and report for laterality, that is right, left, or bilateral of a condition. But the edit applies when you enter an unspecific diagnosis code that is either a complication or comorbidity, or a major complication or comorbidity, or CC versus or MCC. And then it includes other codes, that code subcategory that further specifies the anatomic site. So in the inpatient prospective payment system final rule that was released last month, there's a table. It's table 6key.3a, and it gives you the whole exhaustive list of the codes that you can use the edit 20 unspecified code edit for. So if you have interest in understanding and seeing all of that, then again, I'll post this information there and you can see the whole list. I was gonna name some codes, but then when I saw that the list was really long, I was like, no, you can just go, I'll post it and people can go out. I thought it was just like a couple, but no, it's a huge list. But I mean, if you think about unspecified codes, there are a lot. There are a lot.
What exactly does that mean?
Huh?
So what exactly does that mean? Like, is that to help with the? I didn't even know that they.
So there will be it will be an edit. So when, especially with your billing people, so for them to, once they submit, or if they put it through their scrubber or they put it through their clearinghouse, and you get certain edits that pop up, you need this, you need that, you need that. You'll see that 20 edit, or make sure that 20 edit is appended to or used for these certain unspecified codes, particularly if they're going to affect the DRG because they're CCs or MCCs. So yeah, that was that. And this, so it's actually, it doesn't take effect until April 1st, 2022. So the implementation, it's effective for discharges occurring on or after April 1st. So they're giving you time. So they're providing you information and giving you time to make sure all systems are aligned and a go. And then the implementation date, which really they have those dates for the payer community to understand, like when they need to have their stuff on board and ready to go. And that's April 4th. So they're giving them 3 days. So everybody needs to be working now to make sure that their stuff is ready. It's usually, 3 days after the service, the claim, in most instances, claims drop. So they need to be prepared.
But we know we've talked about it, like next year, they're going to start adding new ICD-10 codes on April 1st.
Correct. It'll be twice a year. Yep.
I don't really know how I feel about that.
It's going to be a mess because I think the reason why I say that is because they're doing it now. They're dropping codes like drip drop stuff now. So it's like, I'm just trying to get acclimated to the changes that just happened that were effective October 1. Now you're dripping stuff. Like, they should have one time when they put together like a comprehensive, this is all the stuff that you need to be prepared for April 1st versus all of this drip. I mean, it's the way they're doing it right now. It makes for a managing nightmare.
And even last year when they introduced COVID, like the COVID code, it was very specific. So, okay, it's a very specific thing, so you're kind of okay with it. But when they start putting in other codes, because auditing is going to be a nightmare, especially retrospective. Because then you have to look at, what code was in effect on this data service? I mean, whereas before, you just knew that you just had to check, you really had to pay attention for any discharges like October 1st. So now you got to, it's just, it's not going to be pretty.
At all. I don't know. I just like, I just think they need to come up with a better way to, I think they just really need to come up with a better way to let people know what is coming. And have it all in one time versus all of these one-offs.
Right.
Because that makes it difficult, at least to me.
Well, we can look to many more disputes like UPMC.
Right. Like, well, I didn't know. But then the thing is always going to be, well, you should have known. You were supposed to know. That's what they're going to say. You're supposed to know. It's your job to know. I was like, I know this, but slow down. Help a sister out.
I think it's going to be really difficult especially for people who rely on encoders, because when you do auditing, you can't reset.
Not on a dime.
So that's why I just will always I try to always make sure I'm comfortable using a book.
And that's going to force that hand. And I think, well, look, publishers are going to be ecstatic. But yeah, you should always, I always still have a book available. Always. I got my CPT changes book in the mail yesterday. I was excited.
I have not, and I need to do book. I mean, people should do it, but can I tell you, I have not really marked up my CPT book since I took my exam. But it's great. It's a great thing to do.
It is.
On an exam, it is a lifesaver.
And it is.
It's just like the stuff just jumps out, as opposed to having to sit there and go line by line and make sure you have the right one. It's just like to have the family codes highlighted, then to have the different little areas highlighted. But it's a lot of work though.
It's a lot to prepare for that. But I mean, again, your system, and I know there's lots of systems out there of people, how to tab your books. But again, you got to think about your time constraint because, and make sure that you have a system where you can quickly navigate to the information. I think I was on I get Reddit pings or whatever, and there's one about coding, and somebody mentioned that the proctor was going to put them out because of all the notes that they had in their books, and they didn't. I don't think they specified CPT or whatever. It was just notes in their book. And I remember my days as a proctor because I would just, you were given instructions on what you can and cannot do as a proctor, and your job is to make sure you follow those instructions. The instructions generally say you cannot have anything taped, pasted, or stapled into your book. So when we do the book check, we're thumbing through, and you're in most instances, if you are working coder, you're going to have notes in your book. Period. You're going to have things to help you or assist you to the various places that you code, or to the various areas that you code. That's common. Nobody's going to have a freshly clean book coming into even if you're a student, you're going to have some notes written, but you can't have like volumes. But my thing was, even if you have those volumes, when you going
When you went out, I can't hear you. I can't hear you.
can you hear me now?
Yeah.
Okay. I think I need batteries. So you can't always have all of those notes. So we would just, shake the book, make sure nothing falls out, make sure everything is everything, and really go to the next person. But you won't have time to really go through all of that reading. Time is a precious commodity when you're sitting for a certification exam.
Let me tell you, I had one exam I took. I had so much stuff written in my book that I couldn't even find what I was looking for. I was like, well, darn, I might as well go ahead and just look it up the regular way, because I couldn't find it. I had so much stuff, I just couldn't. So it could work against you having too much stuff too. But having the CPT book blocked off is, especially for certain sections. Like, I still remember the indirect and direct laryngoscopies, and if it's a mirror, it's indirect. And I remember, because I could see it highlighted in my book. I had all kinds. That was a biopsy. It's just, all those things really help you, and it can really help you save minutes off of trying to find a code. Okay. So,
Good morning.
good morning.
I want to say, I already know I'm probably going to reach out to you because I need to know how to adapt my book really good. My program was like, figure it out.
Oh,
Like,
that's terrible. No,
yeah,
no.
like, they was just saying use the tabs that come inside the book and put them where they go, and pretty much saying you get familiar with it. You kind of figure out your own little
No.
system. But I wish they kind of showed me their book and showed me how they tapped it, what was good for them, because I don't know. I wish I had a little system to start with, and then from there, create, adopt some things and create a system from a baseline system. But like, they didn't even give me like a little template system, like something that worked for them. So yeah.
Well, it is, especially if you're going to take the the CPC exam, because I didn't really need it for. I didn't find the CCSP to be that difficult in terms of their CPT question, but for the CPC, like, they go in detail, so you really, really, really need to know how to set up your book, how to highlight, how to, like, especially when it comes to family codes. You have the parent code, then you have the indents. under that code, like those are family codes. You want to make sure that you have those separated so you don't go too far down. Like you make sure that you keep it grouped. And there are certain things like, especially cardiology, you want to make sure you have that highlighted, because you're going to have a question where somebody is going to have they're going to have a bypass, and they're going to have an internal mammary artery graft, and then they're going to have like maybe a 1 or 2 vessel aortocoronary bypass, so using autologous veins. So you're going to have an add-on code. So you're going to have to know how to pick out the add-on codes quickly. And if you have your book highlighted, it makes it really simple.
I feel like, even though I have medical experience, I feel so fresh and so new, so foreign and uncharted territory for me. I feel like I want to keep my A. Hope that somebody gives me a job with that A, because I feel like even after the program, I need someone that like take their time with me, because even though my job is radiology, in 15 years I think medical terminology, anatomy, base, foundational sciences, going back to it feels so brand new to me. I just feel like I feel so brand new to the medical field once again. So like I'm scared.
Oh.
But I'm not going to let that intimidate me too much, because I really, 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 really want to transition to something else. So I'm determined to learn it. I'm determined to learn it.
Right. So the best way to combat fear is with preparation.
Amen.
So it is definitely important that when you are studying, because it's not, yes, having your book and having things highlighted will help tremendously. But what will also help tremendously is knowing those guidelines.
That's it.
Even for CPT.
Yep.
Knowing, especially when you have you use them, you're talking about sutures. You have to know that that you can add the lengths for the same level of repair. In some instances, you don't code them individually. You add up all of the lengths, and then you use one code, depending on where it is, because you're going to have a question where you can combine.
And to his point, like some of those sections in CPT, you have guidelines or guidance immediately above the codes. You have section guidelines, so you'll have a whole, like if you're in surgery and you're coding in the integumentary system, you'll have a whole set of guidelines just directed for the integumentary system. Again, you'll have them specified for each of the sections. So if you're coding for lesions, there will be a set of guidelines there. And then you'll have what I call parenthetical phrase guidelines. And those are guidelines that are usually in parentheses right up under the code. And so just making sure that you are familiar, because there are certain guidelines that are key test questions, because they're easy to make a test question from. And to Jesse's point, like knowing how to code wound repairs, I'm drawing a blank for the other one, but one is where you have to add all the sums of the lengths together, and the other one you don't. You have to add based on you don't. So knowing which category to sit, I'm drawing a blank and I'm sorry, but knowing which category which one goes into is an easy test question. And so making sure you're familiar with those guidelines going in, so you can highlight them, or you can just make sure you're familiar. To your point about like when you go into a job situation, they're going to train you for what they want you to do. They want to know that you have enough information or enough knowledge core knowledge. That's what your certification gives. I got the core knowledge. I understand, this work. I understand how to do, but they're going to train you to their process. They're going to train you to their systems. They're going to train you to their documentation, all of that. So you won't be expected to come in and be like the expert and do this and do this. No, they're going to train you to them. So even if you've been a seasoned coder at a particular facility and say one day you decide to get another position somewhere else, that seasoning, while it's great where you've been, you're going to be the new person on the block in a new situation, in a new setting. And so they're going to teach you and train you to that new setting. They ain't gonna throw you out there. They gonna throw you out there under the bus. Look, they got too much money riding on that. They don't throw you out on the bus.
Because it's two separate processes. Like, one, how you prepare for your exam is not how you would prepare for a job.
Correct.
It's two separate. Those are two separate skill sets. So, because when you are setting up your book to prepare for an exam, it's to help. It's just to save you time. Period. And when you are working, pretty much you'll be in whatever area of coding you're working in. You're going to have a finite set of codes that you're going to use, that you're going to be knowing off the back of your hand in like a month, because you're going to see them constantly. You won't use the whole CPT book.
Right, especially if you're in a specialty practice, there's a set of codes that because your provider they won't do everything. Right. Yeah. Now, some areas you may see a little, urgent care, ED. You may see a little bit of everything.
But even that,
they're common things that people come in with. Right. So.
Because I used to think that radiology coding was intimidating, but it's really not.
You just have to know that, like, to your point about the parent code and child code, making sure that, because when you go through your index and you look and you land on a code and say it's a child code, you need to always go back and reference that parent code to make sure that it has exactly what it is that you need. That child code is giving you specifics. So say there's, 2 to 3 views that you need to code, or 4 or more views, and say you're doing a 3 code or a 3 view procedure. So then you would make sure you select appropriately the child code that has that 3 views. But again, that parent code has the entire piece of the procedure, and you want to make sure that matches the actual documentation that you have. Hi, Vanessa, welcome. Feel free to come up to the stage. And if you have questions or concerns or just want to chat. So what else is going on with you, sir?
Well, earlier this week, one of my former coworkers had a coding test for a job. It was an E&M. CPT was for must have been inpatient, because it was a lot of, there were a lot of CPT questions about E&M questions.
Okay.
And it's interesting how, it's just interesting how people read questions. And, so because there was one question, a person was admitted into observation for chest pain.
Mm-hmm.
Then the next day they were admitted to inpatient with costochondritis. Then the next day they were discharged with costochondritis. So of course we know that you're only going to have 2 ICD-10 codes, but you're going to have 3 E&M codes. And when I was trying to explain it to her, I'm like, because she had done it all through observation, I said,
mm-mm.
So I said, you have to use the initial observation code. Then when they are transferred, when they're admitted, then you use the initial day for the inpatient code. Then you use the discharge code based on the time. From the hospital, not from the she used the discharge code from observation. I said no.
No, she would once they formally are admitted into the hospital, that's an admission code.
Right.
While they do have discharges for observation and discharges for admission, you have to follow to find out whether or not. So if they had never been admitted, to your point, if they had never been admitted, then yes, that would have been valid to use the discharge for the observation. But because there had been an admission, all observation bets are off.
Yeah. And that was confusing for me at first, because then you have these, then you have a whole separate set of codes if somebody is admitted and discharged on the same
day. Yep.
I'm like,
Yep. So you got to follow. You have to make sure you follow that scenario, and that's a testing. That if you write tests, if you write test questions, that you can take that same scenario and you can create probably 5 different questions just out of that scenario.
Yeah.
Wow. Yeah. I don't know how or when or what it's going to look like when they apply the new E&M guidelines to like inpatient, because it's coming. it's I think next on the scene. But it's interesting if you're living in both worlds and trying not to confuse the two.
I have to say, this was whoever did those questions, it was a good test, because some of these tests are crazy. But it was really, and I remember another question, I'm like, wow, this is good. Because they really wanted to know, do you know the rules? Because it said that the person was inpatient and the provider asked another provider to come and see the patient. So automatically you think that's a consultation.
Right.
Not necessarily.
No.
Because the consultation has to have 3 requirements.
Mm-hmm.
And I'm like, wow. And he did not send a report back to the provider, to the requesting provider. So, and we had to talk about it. I'm like, well, then that's not a consultation. He would be able to bill under an initial day, because he's never seen the patient before. So then, to make matters worse, he saw the patient on a subsequent encounter in outpatient to go over the test that he ordered inpatient. So that's not even that's a regular visit.
Who trying to get over?
Wow. Like, you really, like, they want to make sure that you have to have the 3 R's for a consultation.
Man.
I'm like, wow. I'm like, this was really good.
That's a good test. Or it sounds like it. Yeah, somebody was telling me about, like, it was like we received this coding test and it was harder than anything I ever had to sit for. I was like, they serious about the coders or the caliber of coders that they want at their facility. And not just gonna give you no easy breezy. What is ICD-10 mean? Nobody is doing that.
I had a test once. It was for an inpatient position. They gave you 8 hours to do the exam. I'm like, no. You don't even need 8 hours to do your credential exam. I don't believe that there should be any test over 20 questions. If you are testing for a specific skill set, 20 questions is all you need to know, all you need to ask, and you can figure out everything you need to know in those 20 questions.
Right. Not 8 hours, though.
It was over 60 questions.
Wow.
And they were not easy. I'm like, this is...
Is there a certification that comes with this? It's like, oh my goodness.
When you are asking somebody to sit through that, your hourly rate better start with a 4. Better. Who are you fooling? No.
That is a lot. Wow. Wow.
I've seen some doozies.
Wow.
And then I've even seen places where they want you to pass, you have to get a 100. That's not even realistic.
Who does that?
All these people out here. Oh, and risk adjustment, and I find them to be really egregious. They are really off the hook with those risk adjustment tests. And I've even done. I remember in 2019, I applied for this risk adjustment job, and I got 100 on the test, and they still didn't hire me. They didn't. The lady told me, she said, "Well, even though you got 100, I know that they're going to want to know what your most recent IRR score was." I said, "Miss, I'm currently working as an auditor. I don't do initial reviews. So if I got 100 on the test, wouldn't that mean that I know what I'm doing?" And I did not move forward. I'm like, see,
Wow.
it's all. When I tell you, it's a hot mess out here in these streets.
And that because then it gives, so you have a lot of chatter about, we can't find certified coders, we can't hire certified, we can't. Well, if you're putting barriers in place not to get them, how can you continue to say we can't find?
Right.
It particularly in your case, if you successfully pass their coding exam, their coding test, it shouldn't be an exam, it should be just a test. Their coding skill test. Clearly, you have some qualified, certified coders that you could hire, but now you're adding additional barriers to it. I don't know. I don't know. And then what happened to just training, in-house training?
I'm gonna tell you what happened. What happened with that? I can tell you, when it comes to risk adjustment, you have to know what you're doing to train people, and they have people. It's true. And
here come the tea. Here come the tea.
And you have all these people. I'm telling you, I've had jobs where my direct supervisor was not a coder. So what kind of guidance can you really give somebody? Like, seriously. All they do is they just spout talking points from somebody else higher up who is masquerading as a coder. Because when somebody is telling you, when they're conflicting standard guidelines, they are masquerading as a coder. They're not a real coder.
Not masquerading.
Yes.
Oh, goodness.
I'm telling you, like, wait till you get into risk adjustment, Clarice. It's a hot mess. It is the most ridiculous stuff you've ever seen in your life. It's like, how can you get this twisted? Like, it's supposed to be so cut and dry, but they have made mountains out of molehills.
Right. Like, and so, and which makes things problematic, because, I remember, and it used to just piss me off every time I used to hear it. You would hear somebody in management or leadership who may have heard a little bit about coding, and the one thing that they always wanted to hold on to was, all the gray areas, and you can never get two coders to agree. And I was like, that's not true.
That's right.
That's not true. Not at all. And so that would always be their selling point, like, well, you can't even get coders to agree. So how are we supposed to do X, Y, Z? Because your guidance is right here, and it says do this. Period.
That's all you have to do.
Period.
All you have to do, because I tell even when I'm working with my students, I tell them it's not what I say, it's what the guidelines say. I'm not telling you, Jesse ain't said you got to do it this way. CMS says you have to do it.
Right. And even as a compliance officer, my thing would be show me this foolishness that you're doing. Show me where you got this from. I know what I got, but show me where you got this that says do this.
And whenever anybody can show you in guidelines, that means they don't crap.
It's like that thing with when you were kids and you whisper in somebody's ear and then you tell them to whisper something else and then you tell them to whisper something else, and by the time it gets to the end, it's something totally different, and then and they're running with it. Yeah, those guidelines, they'll save you every time.
Yeah, I mean, I enjoy it, and I think what I like the most about coding is that everything can be fact checked. Like, there's no reason not to know. You can always look something up. You can always verify, which I find reassuring, because then you know you're on the right path.
Mm-hmm.
Like, okay, well, this is what the guideline is saying to do, and that's what I always tell my students, because this week I had to crack the whip. I'm like, why are you guys? There's no need to guess. What is it? This? Wait a minute. Why are you guessing? Like, if you don't know, look it up. If you don't know, go to that chapter specific part of the guidelines at the front of the book, read it, and then go forward with answering the question.
Yeah.
There's no reason to not be sure. There's no reason for uncertainty.
And one of my things I do in my class with my students is when we have our discussions, I'm like, well, walk me through your process. Show me how you got that. Show us how you got that. so that so I can understand where the disconnect is, so I can understand what's missing or what you didn't understand or didn't get, and then show you the proper way to do it.
Because I do something similar, because I give them step by step how to do it, and how they always get necked up is because they never follow the step by step.
They don't follow the step by step. And you can clearly see it. That's why I'm be like, show me. Because then they'd be like, oh, well, didn't I do? You missed 3 steps, ma'am. Yep.
And the crazy thing is, one of the nurses in my group is a former teacher. And I told her, I said, wait a minute. I said, you're really sitting here trying to play me? You are a teacher. You know when somebody's not putting in the work. You can tell.
Right.
I said, you think I can't see that you ain't putting in the work? You think I can't see that? I said, come on now.
That's why I give lots and lots and lots and lots of examples and problems. I was like, this is the only way you get it. This is the only way you get it. So,
as I had a couple weeks ago, one of my students was like, I just need to answer more questions. I said, no, you need to learn the guidelines. How many questions do you have to do before you realize that you don't know the guidelines?
Yep.
That's the problem.
Yep. And you understand, with those questions, or for me, I can tell that they don't know, or they didn't reference, or they didn't read. And I always say, reading is fundamental. Reading is fundamental.
And the whole thing, the coding, and I'll tell any student, the worst thing you can do is try to chase the answer. You don't want to chase the answer. You want to understand the concepts.
Yes.
And
that'll make you a better coder every day. All day.
Because one word can change an entire situation.
Mm-hmm.
Because all they got to do is, the same scenario can happen outpatient, but if they put inpatient, the whole set of rules, they get turned upside down.
Whole set of rules, whole code set, whole everything. Yep. And so they could clearly see you didn't read something.
Go ahead, Vanessa.
Hey, good morning.
Hi.
I just dropped in because I was looking for some groups up here for medical coding. And so I think I've been a part of this room for a long time, but I haven't been on Clubhouse. So I saw that you all were on this morning and just had to listen.
Okay.
Well, welcome.
Yeah, I'm very entry level in this right now.
Okay.
Don't come from a medical background. So right now I am doing appointment setting for an optometrist's office, my eye doctor,
Mhm.
and that's, I guess that's just kind of my way into the door. But like a bunch of stuff happened with that company, and now I'm like with the offshoot call center company because they got rid of their communication center, and so I'm just like working from home doing that. But because I'm not with the company anymore, I don't know if there's place for me to move up. I'm just basically call center work right now with that company. So even though I'm getting, a little bit of insurance here, the terminology, there's not really much room for growth, anymore. And so I am in a medical coding certification program with Career Step, and I'm on part 1 of that. And I'm like just trying to keep motivated because all of it is just like background history, computer stuff, and I'm like, I'm gonna get to the meat of it, but so I'm trying to get through part 1 so that I can get to the meat of it and get to the real deal stuff. But like, I guess I don't know how to, I'm wondering if working in this scheduling position is going to help at all with like something on my resume that has something to do with the medical field. That's kind of where I'm at right now. So listen to you guys, I'm like, okay, they're way out there. So I don't know half of the things that y'all are talking about right now.
No, I think with scheduling, so do you schedule tests or specific services, or are they just appointments, or what are you scheduling?
They're just appointments right now to see the optometrist. It's real simple. It's just appointments, making sure that their insurances are updated, and things like that. It's not too much. I've been having a hard time because I had 2 really good. I'm in North Carolina, so I had 2 really good interviews with the Wake Med hospital out here, but that didn't go too well. I think I seemed too eager about because it was entry-level positions just to get in the door.
Mhm.
And I'm looking back into the interviews and why it probably didn't work out. I was a little bit too eager to ask them what the next step was, you know what I'm saying? Because I know that once I get in here, I want to do something else. So they probably were like, okay, she doesn't seem like she wants to be here long. So I'm thinking, I don't know, I don't know what it could be. But so I'm wondering if that was it, coming off too eager to not be in that position because I really want to get in the door and then grow, so maybe that's what it was that I didn't get those positions. So that was kind of disappointing, but I just don't know, once getting through the courses, is this job enough to have me, once I start applying, what I'm saying, for jobs for coding, is it even gonna matter? Because that's the only thing on my resume that I have that's in my medical field.
You want to say something? Go ahead.
In my opinion, I think that you're trying to do too much. I think that because if you're making appointments now, then that's I don't see a problem with that. I think that that's fine because as you progress in your coding education, you're going to learn more things. You're going to learn coding. You're going to learn medical terminology. So that will also, excuse me, even if not right now, you can't move around. Once you learn those skills, if you wanted to, maybe where you are, you might, because trust me, somebody's doing pre-authorization somewhere along that, for your company. So once you become more familiar with the code sets, once you become more familiar with medical terminology and you actually have some competence, like if they ask you a question, you'll be able to answer it because that's what they're going to do. They're going to, try to pre-screen you to see if you can do it. So once you learn those skills, then you can move up to maybe pre-authorization or even look for pre-authorization jobs. And then once you complete the program and prepare for certification and eventually become credentialed, then you have additional options. But once you get certified, you will find a job, whether you have an experience or not. You will find a job. So
Okay.
I think that right now you should just kind of just relax and just learn as much as you can.
Focus on the studies. Yeah.
Definitely.
Okay. Yeah, because I thought that like I said, I don't really have many people around me that's in this field. Last year during quarantine, I was like, okay, I've been in emergency dispatch that's pretty much my skill and what I've been in since I started working out of college. And so last year I had some time to sit with myself and I said, all right, I'm not really seeing many dispatching companies where I could have a good work-life balance. Everything was second, third shift. So I was like, okay, I need to move forward from this. I want to be able to be in a field where I can move around, where I can have, my weekends back, where I can have, day shifts. So looking at things and looking, can I get certified in something? I don't really want to go all the way back to school because that's just not me. But I want to put my money into like a whole nother degree. So I had to just keep it real. So I was like, found coding, looking through my community college with Great Tech. And then they actually had a whole grant thing where I was able to apply for it, and then I got into career step. And so I guess, my big thing was just like, all right, getting into a big hospital so that I can move around, get into a big hospital instead of like my doctorate was just so condensed into, all right, you're in the call center, so it's just like, okay, but now, since that didn't work out, I was just like, man, I had it was the appointment setting job for the biggest hospital, didn't get that. But that's why I just feel like, oh,
right. I get what you're saying, but
first.
Right, but you're still kind of putting the cart before the horse because appointment scheduling is nice, but that's not a coder, and that's a whole different skill set.
Exactly.
So once you are learning the skills and once you complete the program, you will be able to find a job. And you also you don't want to just limit yourself to brick and mortar. You can find remote pre-authorization jobs. You can find remote scheduling jobs. So don't just limit it to just your area.
Yeah, you're right. And that's what I'm doing. I mean, I'm remote now with the optometry scheduling position. But I do think that, you guys are saying exactly what my mom said. Don't worry about like, where you're at and getting up to the next level, get the skill done first. So
That's right.
I guess I do need to kind of pump the brakes a bit. But I guess that's what happens when you're like in these Facebook groups and like some of these YouTube videos are just like, and I had, somewhat of a mentorship from someone else. She was like, you got to get into a big hospital. You got to get into a big hospital so that, once you get this, you can move around a little easier. So I'm just like, I don't see. So I'm over here, I'm in scheduling, but I'm like freaking out because there's nowhere else to go from it. So if that's not the case, then that does make me feel better.
No. Just relax and just stay the course, learn as much as you can. And as you learn, then you see if you can find positions that can capitalize on that while you're learning, and then just continue to advance in your knowledge and in your studies. And once you get your credentialing, you'll be fine.
Okay, thank you.
Yeah, and usually these programs, they're setting the foundation for you. So, because you mentioned like the terminology and understanding the computer systems and all of that, and then you actually have more experience because you're actually in a system and you're using some of the technology already. So you already come with some of that skill set. So I know it could probably be a little boring for you, and you're like, you know what, I get this, I understand that. give me the rest, but they're building for you. So unfortunately you may have to just trudge on through how they're dripping it for you just to get to that next level. But you could always, if you want to be prepared, and I'm assuming they've provided you with some written material, like if you have your books, you can kind of just browse through the book and look at different things. They'll eventually get to you and test you and train you on those things. But if you just want to kind of peek and see. And the reason why I asked whether or not you were just doing like regular appointments or if they were scheduling tests, because oftentimes if they're a specific test, then you have to justify the medical necessity of that test. And that usually requires an ICD-10 code. And so that would kind of give you some familiarity with what, diagnoses and the codes. Now, I'm sure they wouldn't necessarily require you to figure out what's medically necessary or whatever, but you can actually eyeball and kind of begin to kind of say, oh, okay, I see this code. I see this means that. I see this means that, and to prepare you for the next level information that they're going to provide you.
It's some stuff I see on the computers that they provided me here at home. There's some ICD stuff up there, but they didn't really give us a lot of leeway to use that. I mean, we have to plug in the insurance, but it's just very basic, and it's just like, oh, if you don't know that, then transfer them to the office. So they don't really give us a lot.
Mm-hmm.
But I might take a look around on the computer a little bit more, open some files to see how they do it. I didn't even think about that until you said that.
Yeah.
But you're right. But yeah, it's just crazy what people say to you, that you have to be in such a big place in order to move around. But definitely, but you're right as well. Like I am even trying to just trying to stay motivated in part one, because you're right, it's just a whole bunch of background stuff. Like, because I know how to use a computer. Why is there a whole module on like computer skills?
Because there's a lot of people who don't.
You'll be surprised. Be like, oh, this is the button to turn it on? Really?
Okay, so this is part of it, which is it like, kind of just like, all right, I'll get back to it later. It's just another module of this. I could just knock it out. So I've been, kind of like not as consistent with it, but I'm back on it now because I'm just like, all right, I'm ready to get to the meat of it, at some point. So I had picked it up way more now. So I can go ahead and get through to the important parts to me, I guess.
At my first coding job, because they trained nurses, part of our training was we had to practice attaching documents to email. Now you think, oh my God, who doesn't know how to do that? I can tell you it's a lot of nurses who didn't know how to do that. And I was like, oh my God, are you kidding? But that's what we had to do. Because a lot of people didn't know.
Yeah.
I can believe that. I mean, even in my, since I've, hear feedback. Since I've been, when I was helping my mom, she had a wound and I had to do, I didn't qualify myself as a wound care nurse, seeing as I had to do all these dressings and do all of this stuff. And she tells me all the time, you should have been a nurse. No, I should not. She tells me all the time, you should have been a nurse. You do this so well. And I don't even feel it when you give me my insulin. And blah, 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 blah. She just goes on and on. And I'll be like, mm-mm. But, watching them, and she had a wound vac. So I had to, cut out the foam. And I was like, so this is like arts and crafts. I'm watching them like, oh, y'all problem solvers, but y'all like Bob the Builder putting stuff together to make sure this. And I said, okay, I got y'all. So I can understand the computer will be foreign to y'all, to some nurses. Now with electronic medical record, of course, they got to go in and do that documentation. So that's probably one of the things they was like, well, wait a minute, hold on. I didn't sign up for this. I signed up for this hands-on piece, not this one.
Right. And then now there's a new era of nurses, because now these nurses have grown, they're young, so they've grown up with
computers
and smartphones and all that. So they're totally different. But like, I just remember, like, in my era of like, nurses fought technology. Like, I remember even before I got into coding, because before I got into coding, I had an IT background, so I was seeing computers apart and all that.
I forgot, sir. He got everything.
And I remember working, and I used to be the only one that would restart, because you had to reset it, because back then you had to turn the computer on every day. You had to put in the codes to bring it up, and nobody else knew how to do it but me. And if I didn't do it, they wouldn't be able to bring it. But it's not hard. But they made it hard. So it's just, people just get intimidated, but it's really no need. You cannot break a computer. You could always just turn it off and turn it back on.
True. True. Unless you drop it or something, then that may be something different. But yeah. Cool. Well, thank you, Vanessa. I appreciate you coming up to the stage and sharing some of your pain points. I'm sure others that are new to the field and trying to understand, and why are they teaching me this when I really need to know that? I'm sure that was helpful.
Yeah, no, I appreciate you guys' feedback because definitely gives a different perspective from what I've been seeing. So I appreciate that. Thanks a lot.
Because trust me, when you get into the deep end of the pool, you're gonna relish those days when you can't leave.
I'm sure. Yeah.
Yeah. Uh-oh, I hear feedback. Do you hear it?
I hear it now.
See, it's me. That's why when you see me down here moving speakers, moving stuff all over the place, like I hear feedback and I don't know why. Okay, that's a little better. I don't hear anything yet. Huh?
I said me either.
Okay, so maybe it was me. So I was bringing the phone near me so I can see the people who may come on in the Clubhouse, so I can, I like to recognize people that come in the room. I want to at least say hi, whether or not they feel comfortable enough to come up and talk. I at least want to say hi. And so you're gonna see me looking over here. It's gonna be out the view of the camera, but whatever, it is what it is. At least we don't have the feedback.
I was looking too. I wouldn't leave you hanging like that.
Yay! 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 Let's see, we got a comment here, a question. How much do you charge for tutoring? Do you want to send them somewhere?
Oh, the codenurse.com. I have it's on if you click on services, I have tutoring up there.
And you can reach me at let's see, any of my platforms at PRN Coding EDU, or you can send me, you can direct message me, or you can send me an email at cwarner, WARNER, at ohioprn.com. Did I tell you my situation that I broke my website and I got to put it all back together again?
No.
I forgot I'm talking to the IT person. I should have. So, once upon a time, I had a WordPress blog, which I loved because it was doing multiple things. So I would do my little blog post, and then I would do the video from the blog post, and then I can reference back and forth. But somehow or another, that I broke that. That's been broken forever. So I had to go back and remove links and do all kinds of stuff. So I was like, I'm staying away from WordPress. It was making me nervous. Well, the hosting provider to my website decided that they would no longer support the platform that I created my website in. So while my website was out there, I couldn't make any updates to it. So I'm like, oh my God. So then they gave you options. And of course, one of the options was WordPress. So now I'm about WordPress books and I'm reading to understand better how to do, because I have to be able to update stuff because, our classes change, the dates change or whatever. So I have to be, it can't just be a static, front facing page. I got to be able to do that. So that's on my to-do list. It's to put my stuff together and get my my website back up. I was like, I had my website for 20 years. What in the world?
So what made you pick WordPress? Because I have Squarespace.
It was so I started with Yahoo Small Business. Well, Yahoo Small Business is now being owned and operated and possibly managed by Verizon. So because of that, those negotiations and talks, the site solution, I think it was the name of it, they no longer support that. So the two options that they give you, one is similar to the site solutions platform, but you don't have a lot of variety. It's real bland. And so the other one was WordPress, where of course you have a lot more variety as far as themes and different things that you can do, different things you can add, videos and all that kind of stuff. So that's why I was like, well, I guess I need to learn this in order to fully put together what I need to do for my website. So in the process of that, I'm gonna be like you in IT. We gonna have compliance / coding / IT / you name it. I'm a slasher.
I'm telling you, look, you have to in this day and age. You gotta be able to do it all.
You have to be able to do a whole lot.
You do.
So thanks for your question, Tay. Those are the various places that you can. I guess I can short question. Those are the various places that you can reach us for information. Yeah, I got a group coming up. They're ready to, which is gonna be funny. I got a group coming up that they don't want the full class because, and I think it's horrible that you have people who have invested in programs and courses, but they're still not getting enough, or there's no interaction, there's nothing. And so they have to spend more money to, and I'm sympathetic to that because I'll be like, hey, you done spent $10,000 on this course and you still, it's like, but okay, whatever. So I got a group that's coming in that they're currently taking a course, but just need support, information, accountability, I guess, as well. So this gonna be a different spin on what I normally do. So I'm like, well, you should have just came to me and got my course, but that's neither here nor there. I'll give it to you however you need it.
Can I tell you, that was what I mean, being honest, that is one of the things that I struggle with as a coder and as a business person, because I know the type of service I provide. I know just from the time we've been on Clubhouse, the type of business owner you are, the type of coder you are. And I can honestly say, with the exceptions of me, you, and another woman that I know, nobody else is doing what we're doing. Not at the level we're doing it. They're not. They're taking these people's money. And I get it, because you have people who go for the glitz. They go for the razzle dazzle. Oh, well, this website looks great. This website, they'll look at, that she has this one on her page. When you need to be, what you need to know as a coder is the guidelines. You need somebody who is qualified, and you'll know when you are in. How can you pay any money and you cannot ask somebody a question? How is that even possible? Like, and you have these people who are under the delusion that you can learn it on your own. You cannot. And anybody who tells you that they can, they are lying. There's only a handful of people who are that motivated, who are that directed, and that independent that they can learn everything on their own. The average person cannot do it. I could not have done it. And I consider myself to be a pretty savvy person. I couldn't have, because there are too many moving parts.
Exactly. You're right about that.
You need people to break down. You need to be able to talk through scenarios. You need to be able to say, oh, okay, I forgot about that. I didn't think about that. Oh, that's right. When you do this, you do that. If you don't have that kind of exchange, how much real learning is going on? And because I know, like, what I'm going to do this month is I'm going to revamp, because my whole niche has been nurses. And I'm going to be honest, working with nurses is like trying to herd cats. Nurses, and I get it. I am a nurse, and I've been a nurse for a while. I know how they think. And in my most recent videos, I've kind of gotten really real with it, because I know nurses, like, because like in my last video, I'm like, I said, we all have sold ourselves this lie, like nurses are only people out here making money. No, they're not. There are people out here making money sitting at home, and they don't have to expose themselves to coronavirus to make money. They don't have to jeopardize exposing their family to a contagion to make money. There are people making 6 figures at home, in the comfort of their home, in some comfy boots and slippers and a coffee mug. They are making money. So
That's what I.
Go ahead.
That's what I want.
All right, Terry.
I'm telling you, nursing is insular, and nothing else exists outside of nursing. I've been a nurse for 28 years now. I know I've never thought like that because I was never really into nursing like that. I mean, I love what I learned, and I love being able to help people, but I was never bitten by the nursing bug. That's why I'm still an LPN 28 years later. I never wanted to be an RN. Once I got into it, I'm like, this is enough for me. I didn't see nothing else to see here. I just need to know how to work it into something else, and that something else is coding. So now I'm glad that I can see the pivot and all that, but there are too many scammers out here taking people's money. And I know because I have just like you, I have tutored people who have paid thousands of dollars and they do not know not one guideline. If I give them a scenario with a person that has hypertension and heart failure, they will never, ever, ever say that the person is diagnosed as I-11.0. They don't know. That's basic.
I told you I used to proctor exams for my local AAPC chapter, and I used to open up once I got the list of people who were going to come to the exam. My students knew I always had a test taking strategy kind of component. I tried to do it like either the weekend before or a few days before the actual exam. And I opened it up to everybody that was taking the exam. And so it would just floor me when, people will sign up, they would come. It was an all day, well, probably about 6-hour session where I would give a pre-test kind of to see what we working with and to understand, what types of things I needed to test folks on. And then from there, we would go through each individual section that, I got the people had problems with. So I would have maybe 1, 2, 3 folks that we really had to go through everything. But for the most part, there would be just certain areas that people needed some information on. But it would always floor me, but people would be like, no one ever told me that. And this was pre-online. It was like, nobody ever told me that. No, they didn't tell us that. And I'm like, ooh, they're not preparing you. Not only for the exam, but they're not preparing you for the world of coding if they're not telling you about the guidance that supports the work that you're doing. Yeah, it just used to. It never ceased to amaze me. And I used to always prepare myself like, okay, be prepared for what you're gonna get. And so then people like I've had even people come in with the test or with the time thing, like, I know it's so much time, but can we do this? And can we do? And I'm like, no, they never talk to you about like at least prepare you for what it is that you're doing. Because I've had people who really didn't have like I don't even have that book, ma'am. I don't even know what to tell you. I don't lug books around for test takers. So it was crazy, and it's unfortunate. And like to your point, it's just really unfortunate that people are out here taking folks' money, hard-earned money.
They are, and it's not a little bit either.
No, where was I? I was somewhere. Where I think I was in a Clubhouse room. And somebody was saying, were you in that room? I don't know. Somebody was saying that somebody had a grant to teach them coding. So it really wasn't any out-of-pocket monies necessarily for them to learn to get the information, but they still didn't get any information. I'm like, how you got paid to give this information. Even if it didn't come from the student, you still got paid to provide this information. Like the information we provide here today, this is free information. This is all free information. So, I always say if I'm giving you free information, my paid information, come on now.
This was in 2020. This woman had reached out to me. She was in Chicago. She got a free voucher to learn ICD-10 CM through this program. I mean, everything. A whole year. They bought books. Every book she needed, they bought. She went through the entire course. Well, they all did. And only 3 people passed the exam. When she had contacted me because she wanted to take my class. So I told her, I said, I let her do my class for free. I didn't charge. And it was amazing. I mean, every week she'd be like, they never taught us this. And then she had said that they told the class that you're not allowed to write notes in your book. I said, you have to. I said, who don't do that? I said, but see, and I told us to see, this is what happens. That's one thing that I've always been independent. I never had a problem looking up things. But what coding has made me a show me person.
Mm-hmm.
And I look up everything. See, I don't go by nothing nobody tells me. I go and verify for myself. I said, so see, that would have never flowed with me because I'd have been like, oh, no, right here it says you can do blah, blah, blah. And I would have just kept it pushing. I said, but if you listen to what somebody told you in coding, you'll never have a job. You better learn how to research and look up stuff for yourself.
That's why I slid that whole marketable piece into my tagline, Certified Marketable Medical Coder. You got to be marketable. You got to show some skills. You have to have some skills to say, you can do X, Y, Z on top of that coding certification. You need to be an asset. You need to be valuable to that organization and the profession.
And there's just too many people out here just for the grab. And then you'll have these. Then I have people, and I don't. It used to bother me, but it doesn't now because I know where it comes from. Like I'll have people that they'll ask me 50,000 questions. They'll ask me what my pass rate is. But did you contact AAPC and ask them? Did you contact the HEMA and ask them? No, because guess what? They ain't gonna tell you jack. Because they don't calculate it, because they know that most people that take their courses don't take the test no daggone way. But you wanna ask me because it's me, but you don't want to ask somebody who's gonna charge you $5,000. The same information.
Wow. Spill that tea.
I mean, but it's true.
It is true.
When you go on AAPC, you don't see nothing about our students pass at 80%. You don't see where is it? I haven't seen it.
Yeah.
Because they're not required. And see, in nursing schools are required to post their pass rate, their first time pass rate. They're required. And that's how they get their accreditation. I think that coding should move to that, and I think that would eliminate a lot of this foolishness.
You're right.
But I don't think it'll ever happen because there's not going to be a push for it.
Yeah. It's interesting. And I get it from both sides because but you have a HEMA certification too, right?
Yeah.
Yeah, so you get it from both sides. Like, okay. So interesting. Oh, well, I guess we'll wrap up for today. Did you have any other things you wanted to burning hot topics?
The only thing
tea you wanted to spill?
The only thing I will say is on Monday I start my last job.
Look at that.
Because I promise you, as one of my coworkers used to say, I promise God and a few white folks that this is it. This is my last job because I am not going into it with the aspirations of being there forever and ever. I'm going there. I have some things I want to accomplish. I have some skills I need to learn, and that's that.
Yay! Yay!
Because I have too many skills and abilities under my hat to be restricted, and I need to get myself in a position where I can make it do what it do.
Yes, yes. So what's your title again over there?
CDI.
Okay, okay. I see the CDI stuff coming down the pike. I see it. I see it.
Well, because truthfully, what I want to do is I want to kind of like switch a combine CDI in this position, combine CDI with data analytics.
Mm-hmm.
Because I really want to get into data analytics because I want to get to where the money resides. I really do. And when it comes to data, what I realized years ago, and that's what made me, 2 years ago, that's what made me interested in it, is do you have a lot of people who know data, but they don't know codes? They have no healthcare background. They don't, because it's still, you can do all the visualizations you want, but you still have to be able to talk the language.
Mm-hmm.
You still have to be able to explain it to people. And people still have to be able to see how it really is relevant.
Mm-hmm.
You can have dashboards are nice, but you got to explain the relevance.
Yep.
You got to get the buy-in. So that's where I feel as though I can make an impact.
And I love that. One of the things like we talked about with the future of healthcare or future of health information is preparing people for data analytics and getting the skills of data analytics, because that's you need that. You need that under your belt. Definitely. And then in my studies with public health, oftentimes they're doing research, particularly if it's a research study that deals with patients. There are various ways that they're getting that information, or even if they're doing information or dealing with studies that deal with like morbidity and mortality, they're getting, coded data.
Right.
All of the information is coded data. So when we be talking about stuff, I'll be like, oh, that's ICD-10 code. All y'all had to do was just, provide that. And it's like, well, how do we figure out what we need to do? And I was like, oh, this is right here.
It's really just that simple. That's how. Yeah.
I come in as an expert a little bit on something.
And that's why, if you get the data analytics piece, you'll be a unicorn. You can write your own paycheck because people don't. I mean, people need to know.
Yes, definitely. Well, this was great today.
Yeah.
Lots of information. Thank you. I know the Clubhouse room is dwindling down, but thank you, Terry and Vanessa, for joining us and providing some insight and questions. I love it when I have questions. Thank you all for being here. Don't forget to follow my co-host, The Coding Nurse. He has a YouTube channel where he drops additional hot steaming tea about things related to coding and specifically helping the nurse community understand that there are viable options out there for them that can help them progress and still keep coins in those bags, because I see a lot of nurses that have big, huge, fabulous designer bags. So making sure they keep those coins in those bags.
And what they got to realize is, well, nurses like titles. I get it. I understand. But, I think it's funny because you don't know how many nurses contact me saying, I want to go into CDI. That's nice, but you don't know jack about coding. What are you going to do with CDI if you don't know how to code? What are you going to do?
Do you know what CDI means?
Exactly. How are you going to do it? How are you going to talk to somebody about documentation when you don't even know about documentation yourself?
Wow.
You don't even know what the guidelines say.
Wow. It's a learning, but I mean, you're a viable option. You are a great resource for them to learn that information and connect with the various nurses out there looking to transition. So I'm sure they appreciate you, those who run across you, and so it's one of my desires to get as many eyeballs on you and your program, particularly with the nursing community, so you can help them get to their level. I think you do a great job in, uh, providing that skill set and not necessarily speaking their language because, everybody can kind of speak their language, but their pain points. You know what the pain points are for a nurse and how to approach that and then provide the additional skill set on top of that to help them transition. So whether they need to know all about the coding nurse. And so one of my goals is to try to help propel that, which is why we're here every Saturday at 9 a.m. You can find us. You can come into the Clubhouse room. You can come into the Zoom room, or you can just watch us here on YouTube. In the YouTube description, I will also put a link to the Coding Nurse's YouTube page. And then I'll also put links to the documents that we talked about earlier in the Coding News segment. So again, thank you so much for being here. As always, my motto, be safe, be kind, and don't wish for it, work for it. So until next week, have a great week and we'll talk to you soon. Thank you. Bye-bye.